as they actually present to introduce themselves. So that way we can keep the flow going for today's webinar. We are going to go through a case summary presentation that will be brought to you by one of our partners from Carelon. Then we'll hear a little bit more about the particular area that's relevant to this case, also brought to you by one of our partners at Carelon. And then we get into the part of our presentation today that's less presentation, more engaged conversation and an engaged dialogue around some solutions for this particular case. So that's going to be guided by our partners from the Center for Practice Innovation, Rusty Foster and Nancy Koval. And we'll screen share a document so everyone can see kind of a summary of the case and what some of those brainstormed areas are. For this brainstorming session today, we're actually going to break down the brainstorm into 3 different themes, those themes being engagement and treatment, working with the family, and developing community connections. So we'll remind you of all of that once we get to the brainstorming portion of today, but just wanted to give you a sense of how the flow of today's webinar would go. At the end of the webinar, we are going to save around 10 minutes for Q&A. So if there are any questions or things that are unresolved from the brainstorming that you want to address, we have time set aside for that. And then lastly, we do have a feedback survey that we'll be distributing through the chat box to you all at the end of the webinar today. We understand that you get asked to complete a lot of surveys, and we appreciate your time in completing this one. It's brief. We review all of the surveys and the feedback that we get to enhance and improve upon all of our future offerings. So I don't want you to think that you're filling this survey out and no one's reviewing it. We do. We look very closely and we do incorporate some of the feedback that we receive. So just a little plug for the survey that comes at the end. And lastly, because I'm sure many of you are interested in this, we are recording today's event. So the webinar from today and the recording and the slides will be made available to you. It'll be emailed out to everyone in the coming days following today's webinar, and it will also be posted to the MCTAC website where you can find it later on. All right, so with that, I'm going to keep going. Just a couple things. I've mentioned that this is not a one-off webinar. This is actually part of a series of webinars that we have done. And the real focus is around this idea that integrated approaches to mental health and substance use treatment improves treatment outcomes and reduces the cost of care. And so this series, what it does is we really dive deeply into a particular case and explore the different strategies and approaches that providers can use to promote integrated behavioral health care. Maybe you hear something today with the case that's going to be presented that resonates with you with a particular case you're working with, or maybe some solutions that are raised resonate with you, or you could apply them into your work. So our hope is that you're not only sharing ideas with our case presenters today, but that everyone who's an audience member is listening and learning in as well. So each of these interactive sessions are addressing key topics. And we do have a survey if you are interested in potentially presenting a case in the future. We'd encourage you to reach out. You can also email us at mctac.info@nyu.edu if you have any questions about this case or if you would be interested in presenting in the future. So today is our last webinar for this chapter of the Integrated Health webinar series, but we anticipate restarting this webinar series in the future again. So with that, I'm going to keep going. So as I said, today is our third webinar in our series for this spring. We hope to be relaunching sometime in the future. And we would just ask that you all stay tuned and stay tuned to the MCTAC website and our listserv that we send out regular updates through. So with that, I want to start us off towards the next portion of our presentation today, which is the case presentation. And I want to give a huge shout out to all of the members of the Carelon team who are either with us about to present or are listening in. It has been such a wonderful collaborative partnership to put together these 3 webinars that we have this spring. We could not have done it without the support of Carelon and the partnership and working together to kind of drill down on the details for the case, make sure everything was ready to present on. And I think it's just important to remember that we have a lot of partners out there in the world, and our managed care partners are out there working in this field as well. And so I want to thank Shannon Loveland, who is going to be our first presenter on the actual case presentation. So Shannon, I'm going to advance to the next slide, but if you would like to introduce yourself to the group, we're thrilled that you're here with us this morning. And thank you for taking us through this case.
Well, thank you so much. So, my name is Shannon, and I have been with Carillon now for almost 2 years. I have quite an extensive background in the Office of Mental Health world and OPWDD world. So, I'm very excited to be a part of this today. So, I will go ahead and get started. So this is our member. We will call him John Doe. He is a 33-year-old male who currently lives with his mother, and he is a product of his parents being divorced. He has a relationship with both mom and dad, but does live with mom. He is diagnosed with bipolar 1 disorder, cannabis use disorder, alcohol use disorder, and there's a potential personality disorder component to him as well. He does have some pretty high medical needs as well, including hypertension, non rheumatic tricuspid valve disorder, proximal tachycardia, alcoholic liver disease, hepatic failure, Crohn's disease, and GERD. And he is now considered Medicaid HARP benefits as a 5-1. So previously he was not HARP enrolled, but now he is eligible to receive those HARP benefits. Nothing has come of that yet, but hopefully maybe in the future that can. So this member has had now 2 inpatient mental health admissions in the last 6 months. His most recent one, he recently just got out of the hospital, and that was on, let me just double check here, 426 is when he recently got out his last inpatient admission. He's had 3 emergency visits in the past 12 months for a combination of mental health and medical. He has some substance use issues as well, including the alcohol use and tobacco use. So, as far as supports, he does have a strong supportive family, being mom and dad. He does not have any siblings, and he spends most of his time at home or with dad. But his dad can sometimes be an enabler and allows the member to smoke rather continuously and engage in those kind of behaviors. As of lately, the member has not had been drinking since his discharge from his most recent hospitalization. So that has kind of subsided for the time being. He is semi-receptive and responsive to treatment. Unlike in the past, he was not so much. His non-compliance with medical and mental health and substance treatment is was non-existent. He wouldn't take meds, which is what led to his most recent inpatient stay, is not taking meds, not attending appointments, even if the appointments were coming to him. He is independent. Up until his most recent inpatient stay, he was able to drive and do all of, day-to-day activities that you and I may take for granted. He is a strong self-advocate, very educated, very well-spoken when you do speak to him, and very polite. As far as additional supports, mom is actually his permanent guardian that was put in place at his inpatient stay from back in October, because the member was very uh, not so much non-compliant. He just did not want to hear anything when it came to his medical or mental health. He disagreed with everything and was refusing treatment. So mom is his permanent legal guardian at this point. The relationship with his dad is complicated. It's a good relationship, but it's an enabling relationship. No, like I said, no siblings or additional family support. It's just the three of them. He is unemployed. He obviously has me for his behavioral health case manager. He was referred for health home case management, but he is now, one of the things that came out of his most recent inpatient stay was he is now ACT enrolled and AOT enrolled. So that is huge. And he is also now linked with one of our collaborations we have done with ECMC and Restoration Society, which is the Peer Bridger program. And we were able to get him linked with that before he left the hospital, where a peer would meet with him, possibly get him to go to the Empowerment Academy. Oh, sorry. ECMC is Erie County Medical Center. It's our main hospital here in Buffalo. It's our county hospital that has the psychiatric units. Um, so my apologies for that. But that's where he was inpatient both times. But we do have some additional services now in place to hopefully carry on so we don't end up back at ECMC. And he still is very hesitant to engage in his treatment. He has expressed his desires to better control his medical and behavioral health symptoms. Currently, as far as his Crohn's, he is now no longer on his steroids, and he is no flare ups. He is doing very well with it despite not seeing a gastroenterologist, even though that is recommended with, Crohn's disease, but he is hesitant on that. So as long as he's doing well with his diet and things of that nature, he probably will not attend a gastroenterologist maybe in the future, but as of right now, his Crohn's is controlled. He has very limited insight to his conditions. He doesn't believe he really has a mental health disorder. He does have, like I said, some additional supports outside of his family, being now with ACT and AOT, and now the Peer Bridger program with Restoration Society. He has a peer coming in home and assisting with that. Possibly in the future, maybe VNA, like visiting nursing, just and maybe for some blood work and things like that. Because as of right now, he is on a long acting injectable for his mental health, which he was on the last inpatient stay, but after so long, he did refuse to follow through with his long acting and medicine. So maybe in the future, possibly having nursing coming in to do those kind of things. And once we kind of see like where he is for how he's doing with the Peer Bridger program, possibly exploring more core services once he gets more stabilized in his mental health and medical, to maybe explore going back to work or education or things like that if that's of interest to him. Any questions?
All right. Well, thank you, Shannon. I
You're
think
very welcome.
if we have any questions, we can always, during the brainstorming, flip back to this slide. So thank you so much. So right now, I think we're going to shift to the portion. Let's see here. Actually, someone just chatted in a question. Actually, if you wouldn't mind, Shannon, if we could take a moment and just kind of dive in on this. So someone's asking if we could speak more to his current substance use, stability and insight, and but like a little bit more than besides his recent sobriety. I'm not sure if you can speak to any of that.
I can speak to a little bit of that. So prior to his first admission, he was a heavy tobacco use, occasional marijuana use, and alcohol use. Alcohol and tobacco were his main substances of choice at that time. He did not see an issue with his substance use, and that is unfortunately what triggered a lot of his Crohn's issues was the constant alcohol use. And he would engage in alcohol use at his dad's house, not at his home with his mom. She would not allow it. So he would always go to dad's house for that. And since his most recent hospitalization, to mom's knowledge, she said he has not engaged in any tobacco or alcohol use since coming home from this most recent hospitalization. Most of my contact is through mom, as the member does not typically speak with me. So 99% of my contact is with mom.
Mhm.
I've personally never spoken with dad.
Got it. And another part, another one of our attendees is asking, outside of avoiding hospitalizations and kind of reducing the major physical health issues, are there any other goals that this individual has identified?
As of right now, his main goal, because he does generally hate going to the hospital, it takes a lot to even get him to the point to go to the hospital for any treatment. He literally has to be at rock bottom. And he right now is just to stay out of the hospital. And we're hoping, along with the Peer Bridger program, he is able to come up with some ideas of things he wants to work on in addition to staying out of the hospital. He's freshly out, within a couple weeks. So we're just trying to, at this point, get a baseline and kind of keep him engaged long enough, because his engagement usually by this time has already started to dwindle, and it hasn't yet.
Yeah. Okay. Okay, so I appreciate all the questions that are coming in now. I do want to take a moment for us to kind of dive in on some of the subject matter issues. And then we can circle back, Rusty, perhaps with some of the questions, because I think that'll help generate some of the conversation during the brainstorm. So with that, I'm going to move right ahead. And I'm going to invite Dr. Langer, if you would like to introduce yourself and kind of walk us through some of this material before we continue with our brainstorming today. Not sure.
Hi, I'm Dr. Sam Langer, Medical Director here at Carillon. And the plan that I function with is IHA, which is an upstate plan, as was described by Shannon. Our main hospital up there is Erie County Medical Center. There's a lot of outpatient facilities as well. And in addition, large primary care practices with which we try to integrate our care with them. Actually, I have a project that we're trying to start here, an integrated plan for behavioral health and physical health, and using a consultative model with them. As far as my experience is concerned, I was the chief of psychiatry at Manhattan Psychiatric Center for 14 years, and in that capacity, I taught the NYU and Mount Sinai residents, mostly forensic issues, but also borderline personality disorder, how to diagnose it, and the implications, and as far as prognosis is concerned, recovery and treatment modalities that are available. In terms of today, what I thought we should emphasize is, first of all, that well, it is difficult in some ways to diagnose comorbid personality disorders with bipolar disorder. It's certainly something that one can suspect and then utilize various screening instruments, which can help make the diagnosis and then come up with a more of an integrated collaborative treatment plan. The reason that we want to do that is because personality disorders really require a targeted and collaborative approach. Uh, and I think it's important to emphasize that comorbid personality disorders, especially by a borderline personality disorder with bipolar, really affect the presentation, the incidence of non-adherence, which is very high with this population. So different approaches are required. Certainly it affects the prognosis and additional comorbidities, particularly substance use. What do you see? More mood episodes, an earlier age of onset of bipolar disorder, greater suicidality, which requires obviously a more integrative approach, greater hostility, and a higher prevalence, as I said, of substance use. There's a lot of research going on with this comorbidity, but particularly I wanted to mention a project in Rhode Island called the Midas Project, which is really studying this. They actually call it border polar, and really teasing out a lot of the factors that I mentioned now, and really encouraging a more, shall I say, not only integrative and collaborative approach, but maybe more informed approach. And what I see is, first of all, a lot of times the diagnosis when I do reviews uh, is not mentioned. Now, when I talk to the prescriber, they're certainly aware of some personality traits that are interfering with the engagement with the patient, but an approach that includes both what we used to call the Axis 1 and the Axis 2 diagnoses is not present. And it really then complicates the picture and results in one of the things that I give another presentation about, and that's polypharmacy. The incidence of polypharmacy with bipolar disorder and borderline personality disorder, or borderline personality alone, is very high. People get frustrated, not sure what's going on, why the person is presenting with a multiplicity of symptomatology, and medications are piled on. And what I try to emphasize, and I just went to I'm at the American Psychiatric here in New York State, in New York City this week. And one of the emphasis that I see is not only integrated care, but also a focus on quality of life instead of symptomatology. And with borderlines who also have bipolar disorder, what you see is a significant increase in disability, unemployment, and other psychosocial morbidities. So the treatment, as I said, is a collaborative care model. And there's a lot of evidence base in the literature to support this, and a lot of actually successful programs that are described in that literature. So a best practice team approach, person-centered empowerment, coordinate information to avoid splitting. That's very important. Collateral information from family, and also encouraging the prescriber to really try to go back and find out more about the patient in terms of their hospitalizations, their baseline level of functioning, and what medications, other approaches have helped and what hasn't helped. Have they had any treatment, and have they stayed in treatment for substance use? If DBT is available, certainly that's helpful. On the other hand, it's certainly hard to access at times. So what I try to encourage is just some of the rudimentary aspects of DBT. The other thing I try to emphasize with people, and we actually have a presentation on that as well, is motivational interviewing. As was said about this particular patient, it's very hard to engage him. And I think a person-centered approach and an acceptance of him where he is right now is something that we try to encourage. And I think that again speaks to the integrative collaborative care approach, in the sense that sometimes the PCPs or other people that are treating people who have these kinds of disorders really struggle. And we can provide that kind of encouragement, support, and training as well. Let's see if there's anything else. Oh yeah, the last two things. One is screening. How do we ascertain whether the person might have a personality disorder comorbid with bipolar? There's a lot of instruments. One is the Iowa screening test. McLean Hospital in Boston has a screening list as well, which is quite comprehensive and but short. It's about 10 questions, doesn't take long. And all of you are familiar with screening instruments for substance use, DAST, the audit, the CAGE, the CRAFT, or the one for adolescents, the NIAAA. All of these are very helpful, and we really encourage primary care practices to utilize screening instruments, because Otherwise, things are missed. As all of you know, if you approach a patient with the question, "Do you drink too much?" your yield is going to be zero. But if you have an approach that really, is a little bit more sophisticated, nuanced, asking, how many drinks do you have? What's your favorite drink? That sort of thing. You can have the person go into it and be more open. So again, these are some of the things that we really encourage and provide support and information, care management, certainly, and as I said, encourage everyone to be involved such that all of these various facets of their presentation are addressed. So I was told to be brief, so here I am.
Thank you, Dr. Langer. Thanks for walking us through that. So I think now we're going to transition to our brainstorming part of the presentation today. But before we do that, I do know that there have been some chats coming through that I want to acknowledge. So thank you everyone for using the chat box to participate. I think one question, and this is related specifically, I'm going to go out of order of the questions that came in, just to acknowledge. So one question was about the members' bipolar disorder and wondering if they've been diagnosed via biomarker. So I'm not sure, Shannon, if that's something you can speak to. I'm not sure if you have knowledge of that, but I think that was just a question one of the participants asked to clarify.
I actually do not have knowledge of that. He was due to his first inpatient stay on 10/16 of 23. That's when he was open to us.
Okay.
So when he was inpatient at our hospital, and they're the ones that provided that initial diagnosis.
Mhm.
So prior to that, I'm not quite sure. Even in browsing in Psyches and Healthy Link, there really wasn't much in there.
Okay. Thank you for clarifying that. Okay. And then back to the substance use disorder treatment. Is he engaged in any substance use disorder treatment or have any willingness to? One of our participants is saying, his willingness, his current sobriety is great, but like, how do we sustain this and support this moving forward? So just curious.
So with him currently, he is still having some chronic mental health issues. He still has some self-talk going on and some rambling, not making like much sense when he is engaging in talk and a lot of self-talk. It is less than what it was when he first went inpatient. He was also discharged while still engaging in some self-talk and rambling, but not to the extent. So mainly right now we're trying to get that aspect like stabilized a little more before he can really truly engage and appreciate sobriety.
Think
Right
that
now he is sober, but um, right now, like the mental health aspect is kind of taking top tier right now to kind of minimize his um, symptoms.
yeah, I think that as I think people would agree, approaching him with some kind of variation of motivational interviewing and a harm reduction paradigm rather than total sobriety is the way to go at this point. He's really not there in terms of, I think, accepting absolute and total sobriety. So I think that's where we are. But yeah, a good question. He's really not engaged, period. He has a lot of comorbid medical things and he's not really addressing those very well as in addition to the SUD.
Thank you both for clarifying that. And I also want to thank Marion who chatted in. And we totally agree with this, that it's important to use person-centered and person-first labels, such as, individuals with borderline, just to avoid stigma. So thank you for pointing that out, Marion. We totally agree. And I think that's a great transition point because we are now going to be really focusing on the brainstorm portion of our presentation today. So we have wonderful colleagues from the Center for Practice Innovation. We have Rusty Foster and Nancy Koval. who are going to be kind of leading this portion of the presentation. And so this is where I would invite you to continue the same momentum that you have already taken to the chats to participate in kind of brainstorming. And Rusty is going to lead the conversation and is hoping we can divide our conversation into 3 different themes. So Rusty, I'm going to let you kind of walk us through. I'm going to stop screen sharing right now. So Nancy, you can start sharing. But Rusty, if you'd like to kick things off for our brainstorming, I think this, and I'll be keeping time, Rusty. So I'll jump in to kind of let you know when we need to move to the next theme.
Okay, thanks, Meg. And I just want to, before we start, I just want to thank Shannon and Dr. Langer. It was a very extensive, comprehensive description of this person and the things that this person's going through and what his life is like. And so I really want to thank them. It was very informative. And now we're going to do the brainstorm. I'm going to use a different format than we've been using since the series began, which is we're going to break these into themes. So we would get ideas. I mean, I assume that everybody here, 2 things about the group that joined us today. One is our experience is that people that join have had a lot of experience in mental health and substance use, maybe in integrated treatment. And so you have a lot to contribute to figuring out what would help this person in improving their lives for themselves. And so that's why we do the brainstorm. And the brainstorm, and I know that everybody here has been in brainstorms before, and the brainstorm is we pick an area that we want to think about. People present their ideas. We don't stop to explore those ideas as they're coming in. We just keep going. No idea is too wild. So we actually can have a good time doing this, but it's very informative and we get a lot of information and a lot of ideas out. And then at the end of it, Shannon is going to, from Carolyn, is going to look at this, and Dr. Langer is going to look at these ideas and say, this is a pretty good idea. We're willing to try this. Maybe we'll try this. So they're going to pick 2 or 3 from this whole list, and usually the list gets to be very long. And so it's not that this will go nowhere, that your ideas might be might help Carolyn and in the MCO in their approach with this person. So we're going to start with, and Nancy is like fabulous at doing this, Nancy Koval. She wrote down on the left side lots of information about the person, like a summary of what Shannon went over. And then on the right side is the 3 different areas that we're going to explore in the brainstorm today. And Nancy then keeps track of what people have said about this and has a list, and you'll see the list, and that's how we're doing it. So we're going to start with engagement and treatment. This is you heard from both Shannon and Dr. Langer that this person does have the idea of getting involved in treatment is complicated for him. He doesn't get involved in either in medical treatment or mental health or substance use. And so, and remember, this is an integrated care series. So how can we work together? How can these things all be part of what we might do to help him engage in different parts of his treatment? So here we go. Here's the brainstorm: engaging this person in the treatment process. What would be helpful? And please put your ideas in the chat box. Sometimes it takes a few minutes to get us going, but once we get rolling, we usually roll right to the end. And, you know, we go to about 20 after 11, and then, you know, because then we stop for other questions and answers and the survey. So we have like 50 minutes to do this, to do these three. So we have connect him. This came from Robert Growling, and oh, wait a minute. I lost my,
Looks like, Rusty, would it be helpful if I just read maybe the first in order of what people,
yeah, because for some reason I lost my,
the chat box, it disappeared.
yeah,
In the
not my chat
brainstorm,
box,
Rusty.
the whole thing disappeared.
Oh,
Just give me a minute. I'm going to try to get back into,
Sounds like you may have minimized your Zoom screen. But it looks like,
let me try Zoom again then.
yeah,
Okay, I'm back.
okay, great, great, great.
Hey, technology. At the end, you can help me with my technology problems.
We are a TA resource center, Rusty. so
Okay. So, let's see now. What do we got? So things have been coming in. Now this is all around engagement, right? These things are to help the person engage in the treatment. And then I know people have, this is a question that we can ask later. But we don't really ask questions in a brainstorm. We come up with ideas that you think would be helpful, okay? So Timothy Reingold, can we come back to you at the end? Hopefully you don't mind with that. Valerie Bradley said motivational interviewing, which is something Dr. Langer said, using a motivational interviewing approach. Let's see.
And what I meant by that, Russ, he's really utilizing the paradigm of meeting the patient where he is right now. As somebody suggested, if you come on too strong or use language that's going to turn him off, he's just going to disengage even more. We really try to get him to feel as if we are not judging him. We're not foisting things on him. Well, you know, in a very nuanced way, we are sort of we're forcing him to talk to us. So, but I think that's where to go with this.
Right, and motivational interviewing is very person-centered. So it's letting the person drive the process more than us taking charge. So, and thank you, Dr. Langer, because motivational interviewing, when we say motivational interviewing, that's a very large concept because it includes lots of different skills. So Catherine Simpson said consistent outreach. Okay. Robert Growling, this is where we left off when I minimized my Zoom by mistake. Connect him to a peer and take him to a recovery center. Thank you, Robert. Danielle said involving family in the care. Timothy Reingold, that was the question. Carolyn said family support group for the family. Okay, and I assume just to expand on that, Carolyn, that means you meet with the family without the person. You refer them to a family support group? Is that what you meant? You could write you could use your audio if you just want to say yes or no, or you can write in the box.
I would say that would be helpful if it was both ways. Him with the family and the family alone.
Okay, so you have two different meet with the family and meet with the family and the person. Okay, is that right?
Yes.
Okay, got it. Anne Marie Scott said, be careful with our language, such as not using words and phrases that can alienate, such as not conforming, not compliant, etc. So, some of this, Anne-Marie, is like using person first language. And not using, okay, so non-conforming, not compliant. It's more like the things he's not doing, and maybe focus more on the things that he is doing. So does that sound all right, Anne-Marie, in terms of that, what you were saying? Okay, you could write in the chat box, or you can just get on the audio. Okay, and Jennifer Servey said, linkage with an SUD program that can provide psychoeducation on the substances he is using, MAT options, and a harm reduction approach. All right, so trying to get him to get involved with a substance use disorder program and using a harm reduction approach. Family engagement and psychosocial club to help support strengths. So, and Patricia, do you mean like a clubhouse, referring him to a clubhouse?
Yeah, if that's possible, or something like, like NAMI has some groups, but a psychosocial clubhouse is a good idea. If you can find one with younger people, sometimes it's a lot of older folks and they, aren't as inclined, but.
That's a very good point. That's a very good point. You want to have him be with his age group and people who kind of, they don't have like a long history. They're like just, right, this is early, kind of getting into early recovery. Okay. Because I used to work at a clubhouse. I understand exactly what you're saying. Dwayne said, ask him why he's reluctant to take psychotropic medication. Ask him what he thinks, right? What he thinks about it and what his experience has been. Because, a lot of people have been on psychotropic med and they might have had some weird side effects from it that they didn't like. So what's holding him from using the medication? And Timothy said, of course, we can take that question at the end. That's great. Now, I'm going to have trouble pronouncing this name. Talia. Tilia. I was close. And I had 3 tries before you yelped me out. Okay, so Tilia put, definitely utilize the peer to hopefully help him gain insight into his diagnoses. And or even if he does not want to accept his diagnoses, have the peer help him see the areas of his life that are problematic for him. That way he is invested in his treatment. Okay, thank you, Tilia. Excellent. And Carolyn answered yes, both. Use, have family, and this is the family group meetings. Jennifer Servey said, we have a local NAMI chapter in Buffalo that would be very helpful for the family. So connecting him to a NAMI group, a NAMI chapter. Anne-Marie said, yes, and reframing when necessary. And Anne-Marie, you gotta help me with this. What is it that we would be reframing? I know you're referring to something that we talked about before, but if you could just put in what we would be, what maybe would that sound like? Okay.
Negative phrases such as non-compliant, just reframing, asking like why he might not want to take medications, and then putting it in a way that is not negative. Whenever we say words like that, that person is going to shut down because already they're being felt that they are judged.
Okay. Excellent. Thank you, Anne-Marie. And Tilia then said, I understand what was said before about his mental health symptoms being one of the biggest concerns right now, and it is challenging to address his SUD needs. However, if he relapses, his mental health could potentially decline. It is strongly recommended to do some kind of SUD interventions. And Tilia, I just want to say, this is like, this is the integrated care series. this is an integrated care approach. And so I strongly recommend that you treat, so you're treating both. You do some kind of SUD interventions that promote sobriety. And harm reduction, using a harm reduction approach, but his potential use could cause a decline in his current progress. But again, he needs to be motivated and interested in these activities. Okay. Let's see. Thank you, Delia. And Liz Perry said, see if he's willing to obtain family support and training services through CORE. So he's gonna be in CORE. I don't know if he's been enrolled in CORE, but he does have Medicaid HARP. Is he getting CORE services?
Not at this point.
Okay. But he could, so you're saying, see if he's willing to obtain family support and training services through CORE. So enrolling him in CORE. Delia said, I believe ACT would be his SUD treatment provider, so he doesn't need an external provider, which is great, right? If he goes to ACT, ACT will provide integrated treatment automatically to work on his mental health and to work on his substance use. And when you go to an external provider, this is just my read on this, Delia. When you go to an external provider, you have two providers. It doesn't work as well. If somebody's having trouble getting to one appointment, they're going to really have trouble if they have to go to two different appointments. So if he goes to ACT, he will get integrated treatment at ACT. Eric said, do we know how much and how often he was using marijuana and alcohol? Could be just a brief intervention is needed. So let me just, can I reword that, Eric? And you could tell me if I'm okay with this. But if he's not using a lot of, if he's not smoking a lot of marijuana and he's not drinking a lot, maybe there's a brief intervention that we could do that wouldn't be long-term, right? You could do a brief intervention. And Eric, I don't know if you have an idea of what brief intervention that would be. What would a brief intervention look like? Miriam says, it sounds like his family may already be pretty involved. I think maybe connecting his family to psychoeducational program on how to navigate SUD and SMI may be beneficial. Okay. And I just want to say, we try to do, we try, this is maybe you guys are really taking the integrated care approach, but we try to do the three themes separately, but they're going together, and maybe working with you're not going to be able to engage him if we also don't work with the family. So people are putting together the family and the engagement themes together.
And Rusty, I was just going to jump in and say, I've been trying to keep my eye on the time. So if we were going to try and shift to a new theme, even though we've been so integrated, it would be, that would be the time to move to the next one.
All right. Well, let me just read these last messages. It's not, this is his family. All right. So we're going to, the next one's about his family too. So we're going to leave the engagement. We can come back at some point if we need to. All right. You can listen, it's a brainstorm. So we don't want to inhibit your brain. So we can come back to talk about engagement, or maybe engagement's going to come up with these other kinds of themes. But we're moving towards the family theme, and so Marion White said, it sounds like his family may already be pretty involved. I think maybe connecting his family to psychoeducational programs and how to navigate SUD. Oh, maybe I read that already. Okay. So, but that's really working with the family, okay? And helping the family understand both the mental health issues, the drugs and alcohol issues, how they interact with each other. And this is my own part of the brainstorm. And I think, the mother is really strong about, you can't drink here, but the father, so, and then he might go over to his father's and his father lets him drink. So maybe helping the father understand the impact of substances on mental health. Okay, so Jennifer said, utilize the LEAP approach to address anosognosia. I can't even pronounce this word. I'm going to ask you, Jennifer, to just enlarge a little bit on that. Would you be willing to use your audio and tell us what the LEAP approach would be?
Yeah, absolutely. So the LEAP approach was created by Dr. Amador, and it's an approach that helps to engage people that don't believe that they have a mental illness.
Okay.
I can put the website in the chat for his training.
Okay. So you're saying the one thing that would be helpful because he doesn't think anything's wrong with him is to use the LEAP approach.
Yes, exactly.
Okay, got it. See if he's this is Liz. See if he's willing to complete a wellness recovery and action plan with his peer specialist. So have him do a wellness recovery and action plan. Samantha Oak said, these are great, by the way. You guys are like, you guys are terrific. Connection with solution focus. So this is another therapeutic approach, a solution focus based therapist. He has very little autonomy right now between his mother having guardianship and AOT orders. I'm not sure he's on AOT yet, but he's being referred. What can he have? Wait, let me read that differently. What can he have control over? Might make him more willing to engage in treatment if he's able to have healthy choices to pick from. Okay, thank you very much, Samantha. Okay. Now, Eric said brief intervention. So we're going back to you were saying brief interventions. You mentioned that before, Eric. And this is a little expansion on that. Brief intervention can include education on stages of change, effects of alcohol and marijuana on the body mind, and resources in case he feels like he wants more help. So that would be a brief, and it really is like a psycho ed approach, just like an educational approach, really getting him to understand, the idea of stages of change. And he could I shouldn't keep going into this because this is your idea, Eric. But when you do the stage of change, you could say, well, what stage here they are on the stages. This is how people make changes. This is what everybody goes through. What do you think you're at with, alcohol use? What stage you're in? And it's not like telling him this is what he needs to do. It's just asking him what's his perspective on this. Okay. So Danielle said, family support doesn't automatically mean they are supporting him with mental health and medical care. Okay. Is that a question, Danielle, or is that, do you want to could you reword that so it's like a recommendation? Because the brainstorm are like recommendations that we think would be helpful. What do you feel would be helpful in this? We'll come back, we'll go down, and then you could just add that. Okay. Patricia said, start with harm reduction approach to his drinking. And then Jen said, just a thought about integration of most of these services in one place. Is there a CCBHC within a reasonable distance? So that's interesting. Getting him connected to a CCBHC if there's one that he can get to. And Megan responded to that. Yes, we have several CCBHCs in Buffalo, so that might be something to consider. Jen said a good bit of these services would be available. All right, so somebody else is recommending. So people are recommending thinking about getting him involved in the CCBHC. Okay, and this is Jennifer, is this a link that people can use?
Yes, that's the link for information about the LEAP approach.
Okay, thank you very much. That's very nice. That's very, oh yeah, thanks so much, Jennifer. That was from Patricia. Danielle said, it was to clarify another comment. Okay. And Kelia says, that is a great point, but he cannot be in both ACT and CCBHC. So if he's in ACT, he's in ACT, and they have to provide all the services. And so that would, okay, that's good to know. I'll check the building guidance. That was Jen about that. And let's see. Okay. Thanks so much, Jennifer. That was from Patricia. Statement, Julia, that is great, but okay. CCBHC would be an excellent step down plan for him. That was from Telia. All right. Well, are we out of ideas for working with the family? Are we now? I have it. Could I throw you guys throw an idea out working with the family? I know. Would somebody say yes, that it's okay for me? All right. A smiley. Okay. So, one thing is, I know the parents are divorced, but I don't know how they communicate with each other, but it might be helpful. And so somebody kind of said this before, is meeting with the family, but meeting with the mother and the father to talk about, how mental health and drugs and alcohol work together, and the impact that drinking can have, and so that they start working with them on communicating with each other, and so that they somehow are working together to help their son, and not in conflict with each other. So that would be one suggestion. Valerie said family therapy regarding his parents being divorced. Now, you're saying perhaps this was already done earlier. Okay, but Valerie, are you saying family therapy where everybody gets together, all three of them? And Gisela says, refer parents to Al-Anon. Valerie, I don't know if you could just get on your audio. Okay. If his parents would be open to that, and if it would be helpful, productive. Now, but the conversation would be with all three of them to talk about the divorce.
Yeah, I was just thinking, perhaps, I know he has a relationship with each of them, but I'm not sure if his mother and father interact, and just the repercussions of their divorce on his relationship with both, and just any impacts that it has had on him.
Right. So it's to have a discussion with the person around how he experiences his parents' divorce.
Correct. And if it's impacted his mental health and
Got it,
is a
got it.
potential reason he uses substances.
Yeah. And I mean, I don't know how old he was when his parents got divorced, but that could be traumatic. And we know trauma. I don't know if he's ever had other trauma issues in his life, but trauma is a big piece of mental health issues and of drug and alcohol issues, and especially for people who have co-occurring problems. There's a lot of trauma history in their past. So, all right, well, maybe we'll move on to the next theme, which is developing more community connections. We kind of talked about that a little bit. Someone recommended him maybe joining a clubhouse. But are there other ideas around helping this person expand his community support network? Helping him expand his community support network. Are we out of, we're out of ideas?
I think the work that's already probably happening with peers, and also, this is Talia, the work that's already happening with peers, and then anything new he does with peers would help with his community connections. And I know Tim Reingold had asked earlier, what are his interests? That to build his community connections, you got to figure out what does he want to do? What is going to motivate him? I think of it from a perspective of like, does he want his life to get better? What does he want his life to look like? And then the treatment and the community connections and the family stuff is all going to help him stay on that track. So if he doesn't want to stop drinking, say, for example, we have to ask him, does drinking help you accomplish that goal, or does drinking help you get in the way of that goal?
Okay.
Exactly.
Well, was that, who said that? Was that Tim?
That was Tim, yes.
Yeah, Tim. I must have, I'm sorry, I kind of didn't read your question correctly, but you were saying find out what his interests are, what he wants to do.
Right.
And so if you want to build a more of a community support network, you build off his interests and what he wants to do, what his goals are.
Exactly. Some of my most difficult to engage clients started to engage as soon as I showed that I cared about what they cared about and were interested in. And I found out with two of my clients that I'm thinking of that were both difficult to engage, that as soon as I found out what they enjoyed doing from the past, I asked them to explain what that was like. And in each of those cases, a smile came to their faces.
Yeah.
And I asked them, how can we get you connected to that again? Because in both cases, they weren't doing those things that they had previously enjoyed.
Yeah.
And so I've connected it to their substance use. And again, like Talia says, how does this connect to these things that you enjoyed doing? And I've made some progress with both. And I take the harm reduction approach and gradually work from there. So that's all purely from an engagement standpoint.
Yeah.
And Rusty and everybody else, just so, I mean, just to give some context, we are an integrated clinic. Tim is on my team. We are an integrated clinic. So a large percentage of the people we serve are dually diagnosed.
Well, that's great. Where are you guys?
Albany County Department of Mental Health.
What county?
Albany.
Albany. Okay. Excellent. Excellent. All
So
right.
Rusty,
So go ahead.
I just wanted to jump in and say, this is your time person, just saying, if we were shifting to the next theme, now we're just about hitting time to do so. Just wanted to give you the heads up.
Yeah. I think we kind of shifted
Yeah.
already.
We have about 15 minutes left of brainstorming then before we get.
And the thing is, we break these into themes, but this is a person, and all these things are part of this person's life. And so they're integrated. This is integrated care. Well, when you're, if you want people to be engaged in treatment, you might work with the family, you might make sure you find out what they're interested in, what their values are, what they care about. If you're going to get them involved in the community, you want to start from their strengths, from something that's important to them, and not, because I've done, I've worked in mental health a long time, and I used to like say, well, this is what you need to do, right? This is right. And I didn't ask them what they wanted to do. I was telling them what they probably should do to make their life better. And so asking people what their perceptions and experiences are is key to getting them engaged and to getting them involved with the community, with community supports. Let's see, we have some more things that came in. So this is what Liz also said: explore interests outside of treatment and help connect him to groups that cater to people his age. Okay, so this is another thing to consider is having other people his age with similar, I'm assuming with similar issues, try to connect them with people who he would feel comfortable with, who he's more in tune with. And refer to mutual support groups such as AA, NA, and there are other groups, there are dual recovery groups. Carolyn said, getting involved in things that interest him, that he enjoys in life. So this is a very important thing that people are saying. What is his future plans for himself? Where does he want to be in a few years? And when he this is a motivational literary approach, right? Because you ask him, well, how would he like his life to be? And then he tells you, and whenever he tells you are things that are important to him. And then you could say, and you got to help him with those. And then at some point you might say, well, let me ask you a question. How does your drinking impact on your, getting a job or getting into a relationship, or right? So you could bring those in, but it's more like a question than saying this is the impact alcohol is going to have on your mental health or whatever.
And Rusty, when it was talked about that his goal is to not go in the hospital again, we don't know him to know if this is true, but if there's a correlation between drinking and his hospital stays, help him see that. Like, when you drink, this happens and then you end up in the hospital. And that would only work if it were true, but those who serve him would know if that correlation exists.
Yeah. Okay. Excellent. And so if that's his goal, stay out of the hospital. Okay. And then if you one of the things you could do is a timeline, right? And you can go back and say, well, what was happening just before you went into the hospital? And, and if you see that there's a connection between his drinking and his rehospitalization or his hospitalization, he'll get that. He could see that, right? It's not right. It's the one thing is try to help him see things and not us telling him what's going on, right?
Yeah.
So Timothy, did you want to say something? I know you.
No, just in agreement with that.
Yeah.
Yeah.
Okay. Excellent. Excellent. And Patricia said she'll be right back. Samantha said involvement with the PROS program and CRS services for engagement, education, skills development, education, etc. IR for family involvement, dual disorder treatment. And PROS programs that's a terrific recommendation. I guess well, okay, we'll leave it at that. So get them involved in a PROS program, which does lots of work with people with co-occurring problems. And they offer all of these kinds of services in a PROS program. Other things around community, we know that he has a peer, he's in the Peer Bridger program, and he has a peer specialist that works with him. any other ideas? Any other thoughts on this? Getting him, helping him have a bigger support system than just his mother and father. Any I mean, people have offered some things like PROS programs would also be like expanding his social support. I know he's going into the ACT, so my sense is that he can't be an ACT and PROS at the same time. Any other? You know, I usually don't jump in too much, but I do have another idea, and it's okay, PROS in our CCBHC. This is from Nancy, can be part of can be part of the step down plan. Okay. Catherine said, perhaps encourage him to volunteer at a location of his choice. Okay. Samantha says, PROS and ACT are allowable so long as enrollment in PROS is for no more than 3 months within a 12-month period. So these are these people know the regulations around this. Reimbursement is limited to the ACT partial step down payment rate. Stepping away, okay, that's Timothy. Okay, now one thing, there is this comes out of the motivational interviewing group, and it's called a value card sort, and it's a way of people sorting through these cards, and in each card it has like a goal or a value, like go back to work, get into a relationship. And so they go through these cards, and it's like not interested, very interested, or not important, very somewhat important, very important. So they put these cards into these different piles, and then at the end you could look at the ones that say very important and go, we have like 10 cards here. What would be the top 3? And so it helps people go through these and identify values and goals that they have for themselves. And there's actually one that was modified. The original one was for people with alcohol problems, I believe. And the second one, though, is it was modified for people with serious mental health problems. And so it had more things that had more to do with their lives than would be in the first one around alcohol. And these, I don't know if you'd ever be interested, but these are, this is not a promotional announcement, but we're from Center for Practice Innovation, and these are on our website. And Nancy always has to help me with this. Nancy, are these in the fit section of the website? Like, how do they access if they wanted to?
When we finish the brainstorming, go back to the slides, I can put those in the chat.
Okay, excellent. Thank you. And any other ideas? This is Liz Perry, motivationallearning.org, cites the fall. Hey, Liz Perry had this. Hey, Liz Perry, thank you. She has now, this is not the CPI. This is not, I don't think this is CPI. This must be right from motivational interviewing, Liz. Yes. Okay. Excellent. All right. I don't know. We might. I mean, this has been a great group, and there's been some terrific ideas. And, you know, you could tell by the ideas that people who are on the call, that call in, have real experience in working with people with co-occurring problems and providing integrated treatment. So, and one thing, I don't know if people have been in any of these other calls, but maybe this, I don't know if this will be in the survey, but it really has to do with this new format. The people, you know what you could do? You could do thumbs up or thumbs down in the chat box around, did you like the new format? Well, we broke it into 3 themes and spend time in each theme. Did that work for people? Yes, Gazella said yes. Excellent. All right. The thumbs in, thumbs in, yes. All right.
Rusty, are we also going to ask the team to pick things to try from the
Yes,
list?
we will. Yes, thank you for reminding me. So, all right, yes. So, what we want to do now, we have this whole, thank you everybody for those votes, because we really listen to what works for people, and so we'll keep doing it this way. But we want to go back to Carolyn, Shannon, and Dr. Langer, and of all the ideas that we had, is there any things, a couple things that stand out for you that you think would be something you'd be interested in trying?
Absolutely. I was able to jot down a few of them while we were going through this. So I definitely liked that leap approach that was suggested. So I'm definitely going to put that on a to-do list, so to speak, to go about it that way and do some more. I'm going to hop on that link and do a little more reading on that to get some more information on that. And then also the NAMI chapter in Buffalo to refer the parents to get them some additional support, because mom does work in the field. I did not mention that mom is in the mental health field. So she also is in her own outpatient therapy due to everything. I'm going to, if she doesn't already know, I'm going to kind of reiterate the NAMI chapter in Buffalo. And then I also did like utilizing the peers that we have from Restoration Society, Adam and Rue, who are working with this member to kind of utilize them as the education aspect to get him to see, like, because he doesn't believe he has a mental health diagnosis. He believes the constant self-talk that he engages in and the rambling is quote unquote everyday life. That's quote unquote normal. So utilizing them guys to kind of reiterate the education aspect and kind of meet him where he is and hopefully get him into that empowerment program, which is similar to a pros, but it's through this peer bridger program where it's almost like a program where he would attend daily or, you know, whenever he felt the need to. So utilize those guys to that, to refocus him and reiterate everything that we're just, you know, discussing as a group with him.
Excellent. Thank you, Shannon. And you know, sometimes we, you know, it's always nice to hear if you tried these, how did it go? So if you ever wanted to reconnect with Matak and just say, you know, these are the things that we thought might work, and this is what happened, that'd be great. You don't have to, it's you know, but it's helpful for us too to hear. And could we switch to Dr. Langer? Dr. Langer, did you have any thoughts on these? We still have Dr. Langer.
Yeah, somebody mentioned the anosognosia, which is, you know, basically denial of illness, and certainly, you know, poster child for that. So you know, any approach, whether as I mentioned, the you know, more of a patient-centered, meet him where he is at this point approach is important. But the leap suggestion, I think, is really very, very positive.
Okay. And And so Leap and any recommendations that would be around meeting the person where the meeting this person where he's at.
Yeah, well, I think that most likely he's experienced the mental health field is making a lot of suggestions for him that he doesn't want. So
Mhm.
any sort of nuanced approach to him, I think all of these suggestions people are making, I think would be really helpful. Pros, for instance, again, it's not a mental health thing, so he might accept that. This is an intelligent guy who obviously at baseline was quite functional. So again, getting back to that level would be really very positive.
Okay. All right. Well, we're going to I'm going to turn it back over to Meg, and thank you so much, everybody, for being involved in this brainstorm.
Yeah, thank you, Rusty and Nancy, for facilitating this. And as Rusty just said, a major thank you to you all who participated. I think this has been one of our most fruitful conversations in terms of the chat box was constantly being filled with really great ideas. People were able to speak up and really, kind of give further details or information about what they were chatting in. So we appreciate that. And again, I also want to say thank you to the Carillon team for joining us and talking through this case and providing more information when we had further questions. We really appreciate it. And hope that you walk away with some thoughts or some ideas that might be helpful to support this member in their health journey. So with that, we have about 7 minutes left. So as you can probably see, our wonderful MCTAC colleague, Nadej, also known as the MCTAC admin, has chatted out the survey link. So we're going to ask, oh, hi. Hello, Rusty, I think your little friend in the back, the dog, is saying hello. We have a guest star, a little cameo.
Adam.
How sweet. So if we're asking, while I'm fangirling over the dog, if you wouldn't mind filling out the survey. Again, we review all of the feedback you give us, and we try and alter and tailor our future upcoming offerings based upon the feedback you're giving. So if you have thoughts, if you have feedback, please share it with us. We really do appreciate it. And I, again, just want to thank all of my colleagues who've been part of this webinar process, from the Center for Practice Innovation, OMH, OASAS, DOHMH. It's been quite a team approach. So I want to thank you all for joining us. And also just to see if there's any questions or last minute comments anyone wanted to share as we close out. We have a couple more minutes, so we are here. If you have anything you want to chat in the box, feel free, or if you want to unmute yourselves, you are welcome to. But with that, I think I want to thank everyone for joining us today. Again, thank you to the Carillon team for sharing this case, speaking to the details and, of everything. I think it was really helpful for us to be able to kind of have a live dialogue about this. And I want to thank you all for joining us. So if you have any further questions, please don't hesitate to reach out. We are here, and please take a moment and fill out the survey if you would not mind.